I'm just doing that to make Jan nervous. Welcome back to the first official episode of the 2020 Users Conference. We had our little kickoff this morning. And from here, now we have lined up this week's classes and next week. You're going to get up pretty soon, actually. We'll post the rest. This is going to be the first thing to discuss, and that is telemedicine, PCC's tools and best practices. Now, I want to be clear. We are not, I'm actually going to leave a fair amount of the PCC tools discussion for the classes to come up. So let's walk through the administrative part of this, and I'll be a little bit more descriptive in terms of what I'm going to talk about. First of all, if you're watching this live, you're already on the live session, and so you don't need directions to get here. However, again, we direct the conversation, the chatting, to the live session in the UC chat tool. It's Mattermost. Go to live session, type away. We've got our PCC people monitoring. Questions will be forwarded to me. We're going to have time at the end of this to take questions. So let's see what we can accomplish in the next 60 minutes. Let me just click here. All right. I'm trying to this is cool. I'm using a new tool. Anyway, let's cover really quickly what our goals are today. First of all, we are going to embrace telemedicine for what it is. I've got a tremendous amount of friction implementing telemedicine in some corners of PCC, and we want to embrace it for what it is. It is really good at some things, and there's some things it's not great at, but we're going to discuss that a little bit. And I'm going to focus more on the why and then on the how, but there's definitely going to be some discussion about how. I am going to be talking about PCC things, but I'm going to be largely focusing on the broader picture. We have other telemedicine classes coming, and we have portal class coming tomorrow, for example. A lot of things that are close peripherals to what we're discussing today are going to be discussed in more depth soon. All right. So this is a graph I put together. I just updated it this morning so it would be most accurate, showing the telemedicine use of PCC clients around the country. What this is just an indication of the percentage of clients who used at least one telemedicine code every week going back to the beginning of the year. Okay, and so what you'll see is the line remains steady but boring in the 10% range, let's say. That means 1 out of 10 of our clients used a single CPT code during a given week in January and February, and then right there in the middle of March, it took off. That line goes, hold on, I can do it over here, I think. This line right here, I hit the wrong button. But this line right here, you can see this is almost a straight vertical line, and that's when COVID hit. Right now, PCC clients are hovering in the 90 to 92% range. What that means is 90 to 92% of you are using telemedicine. You're billing for telemedicine at least once a week. There are a couple interesting things to note about this data. Number one, you see right here this little downward trend, and I only officially measured up through 2 weeks ago because last week isn't really fully measured yet. But I will say that it looks like there seems to be a slight downward trend in the use of telemedicine right now, which is interesting. I'm not going to conclude anything yet. The other thing I want to point out that is, and I should have probably drawn this line, and maybe I'll do that for the podcast or for the webinar on Thursday. But if I were to, instead of just use a single telemedicine code, if I were to indicate the number of practices who are at 5% or more, like people who are actually using it as opposed to just like accidentally using it, this would be a lot flatter. And a lot of who I'm going to address today is the people up here, above this curve, the people not using telemedicine, and the people right in here, potentially the people who are barely using telemedicine. All right, but I wanted to give you a sense of what your peers look like. Right here is also a measure of the volume of telemedicine. And what this shows right here is pretty steadily since March 30th, our clients have done somewhere between 38 and 42% of their sick visits using telemedicine. It's it is declining slightly, but it hasn't really dropped off or anything. It doesn't continue to decline. It looks like, 4 out of every 10, 2 out of every 5 sick visits for our clients nationally is being done using a virtual code that's either over the phone, through your portal, or using a video chat. And that's what those little different colored segments refer to. We have more to talk about in this regard. I'm not going to talk about it here today, but I just wanted to show you that for the average PCC client, a big chunk of those sick visit codes are coming in right now as virtual visits. And I don't want to say here's why, but here's the comment I've made many times lately. I've spent endless hours the last 6-8 weeks talking to practices who are struggling, trying to find patients, worried about their bottom lines, worrying about making payroll, worrying about making rent. And when I ask them, I say, well, have you started doing your patient recall? Well, we haven't really fired that up yet. And I go down the list and I always ask, where are you on telemedicine? How many kids have you seen this week using one of the video options or using a phone? And the pushback I most commonly get is, I'm not comfortable doing that. I don't think you can do an exam without, I don't think you can do a visit without a physical exam. And I would really like to challenge that. Now, maybe, we'll see who's on the live session and maybe things will blow up. But look, there's a significant amount of evidence that the return on the investment of a physical exam is very low. Don't get me wrong. There are plenty of things you have to do with a physical exam. There are plenty of procedures that require the patient to be in front of you. But the real return on a physical exam is quite low. We're going to get into that in a little bit. I'm surely someone can be the volunteer to say in the live chat, well, if I can't palpitate an abdomen, I'm guaranteed I'm going to miss something with some kids someday. And I'm just going to always ask, when's the last time you found something that you would not have spotted otherwise? It doesn't happen very often. And if your choice is to not do anything or do what you can do, at least do something, I'm going to fall in the latter camp. And so this slide right here is the joke I told at the webinar a couple weeks ago, and then a bunch of people who chimed in saying, I've been saying the same thing. And it's the joke about this guy, the guy who's trapped in a huge flood, and the waters are rising. He has to climb to the roof of his house to escape the water, and the boat shows up from the Coast Guard and says, sir, please jump in the boat. We can save you. And he looks at them. He says, my Lord and Savior will save me. I believe in God. He'll protect me. And so the boat takes off, and then another boat comes and says, hey, sir, can you get in the boat, please, quickly, help us save you. We don't want you to drown. He said, no, I believe in God. God, I've been righteous my entire life. Please, I'll be fine. And so they leave, and the water gets, a little bit higher, and he's now sort of standing on his chimney, and the helicopter comes by and lowers a rope and says, sir, grab the rope and we can take you to safety. He said, no, I believe in God and he's going to take care of me. So unfortunately, the water goes a little bit higher. He drowns. He arrives at the pearly gates, and he's, all frustrated. He says, God, I've lived a righteous life, and I've done nothing but good deeds. Why didn't you save me? And he said, what are you asking for? I sent you 2 boats and a helicopter. The point of that joke being, look, right now, nobody is going to, you have to save yourself. You have to work to save yourself. No one is going to come down from the sky, Deus Ex Machina style, and hand you a solution to the problem of COVID. Nothing is going to go away. No problem is going to be wiped out. God helps those who will help themselves, right now is our motto. And telemedicine, although imperfect, although maybe makes you feel like it betrays your belief in the medicine that you perform because you don't get to do a physical exam, or as Barbara Howard put in her video to me the other day, she was like, it hurts her heart as a physician to do sometimes do these things. The fact is, it is what is keeping a lot of our practices open. If 40% of your sick volume, on average, comes through telemedicine visits, you've got to pay attention to that. So what does this mean? All right. we're going to walk through right here some of the tips and tricks and best practices that we've seen that correspond to the use of telemedicine or focus on telemedicine. And I'm going to encourage people here to throw out their tips and tricks into the live session. So everyone who's reading this can see it. If we see something that's going to be a bright idea, we will share it with everyone. Hopefully Jan will see it and copy me so I can say it, but maybe, by all means, you can read the live session while we're going here. So the first thing is I'm going to tell you is start with the obvious. The AAP actually has compiled some really, really great resources for telemedicine. They've put checklists together. They have clinical guidance. They have coding guidance. You can type in that really long light gray URL, services.aap.org, et cetera, or you can type the short one down below, bit.ly/AAP_telemed. All right, and that will bring you to their page about this, and it's got tremendous resources on there. If you have not really felt comfortable with telemedicine yet, this is the first place I would send people. All right. So that's number one. So step two. First of all, I want to know, did everyone with kids have this Melissa and Doug puzzle? Because I remember I was trying to think of how I could get a map of the US, and I was like, oh yeah, there's the old Melissa and Doug wooden puzzle. But the first thing I'm going to tell you to do, and this is even for those of you who are already using telemedicine all the time, please lock into your local state rules. The billing and coverage for telemedicine is really variant nationally. And if you're in certain places like Vermont or who else offers Parity? I think Alabama does. Kentucky does some really interesting things. What you read online from other people about what's covered and allowed in telemedicine may not be accurate unless they are posting from your state. We have states where they are telling people absolutely do your well visits using telemedicine. Do the parts that you can do. They're incredibly important right now. Do the anticipatory guidance, do the depression screening, have all those conversations with the parent, and then bring them in when you get an opportunity, or when they come in next, do those procedures you weren't able to do and bill a 99213 for it. We have states who are saying that right now. We also have states who have absolutely zero guidance whatsoever, and you don't know what you can be doing. You definitely need to start by finding out what is happening in your state. One place to get this information, of course, is at the COVID forum that PCC and PMI have put together. Paul Vincieri's hosting it. You can go to forum.pediatricsupport.com. We are having people dump all their answers into the forum so you can read them. Also, there's PCC Talk, where you can come to PCC Talk and ask a question and say, hey, anyone else in my state of Texas or my state of Arizona or California, what are you hearing from Aetna? What are you hearing from United? Put that information in there and leverage it. I'm routinely surprised by when I look at the coding patterns of our clients, and I see practices who are not only in the same state, often in the same town, behaving so differently. I also want to just express my disappointment in this puzzle because it always has us connected to New Hampshire, and we're really separate states. Even the New Hampshire people wouldn't want to be connected to Vermont either, but that's my only complaint. All right, next item. Okay, this is a really, really great time to implement a credit card on file policy. If you haven't done it yet, please do this. I was talking to a doctor yesterday, and she was like, yeah, up until now, our credit card on file policy was largely a punitive thing. Like when we had people who were running balances or who had skipped bills or whatever the case may be, we would make them put a credit card on file. And now, not the excuse, the reason is, hey, if by putting a credit card on file, we are reducing our contact with each other. I don't have to take your credit cards. I don't have to take your cash. You don't have to hand them to me. We don't have to send bills to you. You're reducing exposure to each other. Now, remember, you can just go to learn.pcc.com and your portal can store multiple credit cards in the portal. So you can turn to your families and say, you can You can send a portal message to all your families. Actually, with the August release, I believe you'll be able to send a message to all of your families. They will get a text message saying, hey, don't forget to put a credit card in your portal so that when your bill comes in, we don't have to lick a stamp. You don't have to put information into an envelope. It just is automatically paid. This is a really, really good time to leverage the safety aspect of having a credit card on file and take care of that once and for all. All right. One of the things that I want people to slow down and think about, this is that, now that most of us have been doing telemedicine for a little time, we can get a little bit better at it. And let's talk about the visits that should be telemedicine visits and the visits that shouldn't be. All right. So we went and looked through all of our clients' visits going back to the beginning of the year. Actually, no, I take that back till March. And we grabbed the top diagnoses. Let me restate that. We grabbed all the diagnoses and we are listing the top diagnoses for in-person visits, March, April, May of this year. And so what you see here is you've got URIs. Now, general symptoms and signs, the R50 and R69. I know that some of you have these things memorized. Not everyone, right? But under the R50 to R69 are things like fevers and so forth. You've got symptoms and signs involving the circulatory and respiratory systems. Middle ear, our friend otitis. Okay. Now you'll see that some of the behavioral health starts to creep in. Okay, a little bit. Let's take a look at what's happening in the telemedicine land. Okay. These are the #1 diagnoses for telemedicine visits for our clients. And right at the top, behavioral and emotional disorders with onset usually occurring in childhood and adolescence. That's all of the mental health work. Okay. General symptoms and signs. Parents call with a fever. Okay. Fever does not require a physical exam. Dermatitis and eczema. I bet right now the number of pictures of rashes coming through the portal going into PCC have probably increased exponentially in the last 2 months. So if you go through this list, I mean, if I do this, you probably can't follow along, right? But the point I'm trying to make though is there are some visits that unequivocally are just as good and even sometimes better as telemedicine visits than they are with in-person visits. Why would you have a patient with a behavioral or emotional disorder come and sit in your waiting room, waiting for you to see a patient who may be sick with any communicable disease, not just COVID? I mean, and Lord knows because of vaccines, it could be measles or pertussis right now. Why not schedule that visit for a time and a place that's mutually convenient, have that patient in a place where they're comfortable, and engage them very directly? One of the things that I tell people to do is find out what your patients are struggling with right now. All right. Go to your Facebook page and say, are you, and because your parents right now are really struggling. Do you have issues with learning because your kid hasn't been to school in 2 months? Are there sleeping issues, toilet training, whatever those things are that you can talk a family through? Go right to Facebook and say, our clinicians are experts in toilet training, experts in helping your child get back to sleep, helping with, managing learning problems. Call us now to schedule our personal one-on-one telemedicine visit with you. So if you are like most PCC clients and your business is down 30%, well, guess what? I bet 30% of your families have an issue that they would love to speak to you about one-on-one. You can get your volume back to where it was by reaching out to your families and engaging them on these things. All right. Now, another thing that I see happens a lot with telemedicine. I had my first telemedicine visit the other day. It was very interesting. It's always funny to be on the other end of these things. Please set expectations. And there are a lot of things that you can talk about here. So for example, and some of the content I'm about to describe, maybe you can get from your telemedicine vendor. Okay. You don't necessarily have to invent any of this. In fact, I wouldn't invent any of this. You can go to the forum, you can go to PCC Talk and ask others what they're using. But Start by giving your families a couple sets of instructions. Download the app before our telemedicine visit. In fact, some telemedicine vendors allow you to create the accounts for your patients, and you can do that for them. Your staff can do that for them and push the account information to that family. All right. Explain to them that, check your phone to make sure you're on your Wi-Fi and not your telephone connection before you call. Here's how to hold the camera. Here's how to get good lighting. Make sure your kid is actually available when you do this. If I'm supposed to engage with your child, or if I'm supposed to look at something on your child, they need to be there. I have a number of doctors who report that they turn on, they go to do the telemedicine visit and the kid isn't there. This is going to sound like a joke, but enough of you know this isn't true, or this is true. Remind people, especially for those early morning visits, to be clothed for their appointments. There's a little bit of telemedicine roulette going on right now. The moms forget that they're on camera. So set expectations. I think it's also important to, for all of us really right now, to leverage one of the things that's happening with telemedicine, and that is the difference with waiting rooms. So 6 months ago, for some of you, it was really cool to have a big waiting room and have families show up for their 2 o'clock appointment, and they don't get seen until 2:30. That's perfectly normal in your practice. We know that some of you are always on time and some of you are never on time. But to have this big waiting room right now with people who can potentially expose each other to communicable diseases, that's not viable anymore. This is your chance to help your families stay on time and help you stay on time. You're in a venue now where if you're going to be late, in fact, you can probably, with a couple clicks of your button, send a note to your staff to let the people following, hey, he's just running behind, or whatever the case may be. You want to make sure that when it's finally your turn to see the patient, they're ready to go. That's something that in a busy pediatric practice, you always have another exam room to go to. But if that's not true in a now, when people aren't necessarily sitting in your waiting room. All right. So the next item, I've heard people say these words very specifically, and I want you to make sure that you understand this correctly. Okay. You should, every single visit. So you know what I say every call right here. I want to edit the slide in real time and say every visit should begin as a telemedicine visit. And what I mean by that is there should be no patients walking into your office right now. Everybody who wants to visit you and engage with you needs to start with a telephone call. That well visit you made 6 months ago, before they come to your office, your staff needs to screen them. Your staff needs to call them up and say, hey, we know you have your well visit tomorrow. Yes, we're going to see you. Let's just go through a little symptom checker. Has anyone in your family, had a fever? Has anyone had a cough? Has anyone had trouble breathing? Whatever the COVID pre-visit stuff is. You want to have all that stuff. You want to do it multiple times. You want to do it a day or two before they come in. You want to do it an hour or two before they come in. And every single one of those visits should begin that way. And if it turns out, as soon as that mom says, well, I've had a bad cough and a fever for 3 days, you say, sounds like you should stay at home. Instead of coming here for your 2 p.m., why don't we set this up and we'll do a telemedicine visit? And we can talk about whatever it is, the enuresis. We can talk about the sleeping issue. We can even talk about, the headaches, or we can talk about the rash. You can just send me a picture. All right. My practices who have that kind of workflow working are the ones who are definitely seeing the smoothest transitions right now. Another way to think about it is try to treat the process of seeing your patients as similarly as you can relative to when they came to the office. So for example, right now, when your patients come to the office, they check in at the front desk, they get their demographics confirmed, then they wait in the waiting room, and then a nurse brings them in and puts them in a room. You can do all of that in the telemedicine era. if your patient's appointment is at 12 o'clock and your nursing staff can call the mom at 11:45 and say, hey, have you downloaded the app? Are you in a quiet, non-distracting place? Do you have light? Is your internet good? Okay, great. And are you still at, 20 Winooski Falls Way? And are you still at this phone number? And they can do all of the demographic stuff in advance and confirm it. All right. There's no reason why you can't make sure that the patient who gets delivered to you is all locked in and ready to go for your visit. I have to drink something just a second. We are not sponsored by Coca-Cola. The other thing is, this is also where you can make sure that you can clarify how this is going to be paid, because if this is an ERISA plan and they've dropped the copay, and that means that they're now you are eating this copay. All right, you better know that in advance. Or this is where you can, well, now with the release next week, you'll be able to check eligibility on the fly. Lock in as many of your normal workflow steps as possible. And this is also your chance to potentially improve a bunch of them. Okay. So here's a big one. And I'm trying to figure out, is that like a snake bite? Who knows? It's not a snake, but I'm just kidding. But one of the things that you should really pay attention to doing is gathering as much patient information about the visit as you can before the visit. So let's begin with demographics. Okay, yes, you can put a demographic form in the patient portal, and no, right now it does not automatically push it to the patient and make them fill it out, but you can get your staff on the phone and say, can you go to the portal and complete this demographic form before your visit starts for us, please? This is keeping us safe and separate. We don't have to worry about having you come in and fill any of this out. You can get all those demographics that way. Your nurse can just do it on the phone. It doesn't matter, like whatever your workflow looks like, you just need to do it. You should also, one of the things we've learned is that you need to ask your patients where they are calling from. If you're from one of the states where where one of your patients is on vacation somewhere and they want a med called in at the end of your appointment, you may have a problem just as you do today. Different states have different licensing rules that allow them to doctors to practice outside their state. It really does depend. Asking this question now, especially as we move into vague vacation time, even though not everyone's going far, I do think it means it's going to be more driving vacations or driving holidays. You're going to have families who are just not in your state. And last but not least, pictures. Now, the PCC portal makes it really easy for your families to take a picture of a rash or some behavior or whatever the case may be and push that right into the EHR. And we don't do the videos because every one of our clients' systems would be like overwhelmed with videos in 2 seconds. But they can send you the video. It doesn't. My point being, you can sometimes see a rash more clearly from a high-res picture from your phone than you can using a telemedicine visit over weak Wi-Fi. So I hope that makes some sense. Now, normally, I do not talk this much without asking questions. I've actually blown through a bunch of slides really quickly because normally I slow down and ask some questions. So I'm going to stop and I'm going to look at Jan through the glass and say, Jan, is anyone asking any questions, or are they just stonily silent? Let me see what they're saying up in the live session. I'm going to dare read these things live.
Live session has some discussion, but
okay. So I'm going to agree that I overstated where the fever does not require a physical exam, or I will say a fever may not require a physical exam. Okay. My point being, I want to really distinguish between those things that require a physical exam. All right. Those things that might require a physical exam and those things that do not require a physical exam. Certainly an extended fever, certainly, there's one little curveball to throw this, and obviously I'm not a doctor, so take all of this with a huge grain of salt. A patient with a sore throat, fever for 3 days, or whatever's fitting the COVID profile right now, you may not want them coming into your office. You may be meeting them in the parking lot, or you may be sending them to whoever in your town is accepting the potentially COVID patients. That's the stuff I want you to, the thing I really want you to think about is, what types of visits do I want to attract to my telemedicine, and what kind of visits do I want to attract to the in-person visits? What else was I going to say about that? I'm also going to double down. Am I discouraging family using cell phones? No, not at all. I think that's in fact what most of them have. What I'm only discouraging, if I'm discouraging anything, is using the videos to capture pictures of the rash, or whatever the case may be. Rashes and injuries and stuff like that, when you take a picture with your phone, they tend to be much higher resolution, and you can ask for your parents to send that to you in advance through the portal. So the one thing to keep in mind, depending on what state you're in, you may actually even have full parity for a phone call, as well as for a portal message. Actually, I don't know about anyone who does full parity for a portal message yet. Maybe there might be someone. And what do I mean by that? So if you are I was just talking to someone yesterday, if you are in Alabama and you have a patient who cannot come in, okay, you can actually give that entire visit on the telephone, and based on time, you will be paid for a 9921X code without the video or anything like that. So if you spend 15 minutes talking to that mom about anything, because it's all counseling when you're doing it that way pretty much, you get a 99213. You spend 25 minutes on the phone with a mom, it's a 99214. All right. So if you live in a state that does it that way, you should absolutely be taking advantage of that. However, if you live in a state that doesn't do this, this is where we have data that can help you. You should be going to your state legislators, you should be going to your payers, and you should really be also leveraging your families and saying, hey, I'm sorry that your insurance company is dropping the copay from this. No, I'm sorry, I'm taking that off. I'm sorry that your insurance company isn't covering this phone call. So guess what? The credit card that you have online in the PCC portal, I've got to charge you $70 for this. They're the ones who've decided not to pay us. You are not the cause of the problem. All right. The more you can get them used to paying for portal exchanges, paying for emails, and paying for phone calls, the sooner pediatricians are going to start to get recognized for all the unpaid work that you've been doing since the beginning of time. All right, what else will I say? Well, hold on, I did get an official question, and then I may jump back in. If you telemedicine the visit and then bring them in or to the parking lot for just a test, a rapid strep, send out culture urine, can you add the test procedure billing to the telemedicine visit billing? And that's an interesting question. And I would say, well, you know what? I am not a coder, and my coder's in the other room, and she's going to give me the, the cutoff sign in a second when I start making something up. But I'm going to say this: if you do a telemedicine visit and it does lead to, let's say you want to do a rapid strep on a kid, I think at that point depending on what it is that you're doing for a lab or for a culture or something like that, you may end up with a 99211 in some of those instances, and you're not going to have a telemedicine visit and a 99211 on the same day. What I would say is that it is perfectly reasonable to have a telemedicine visit and have a lab, a culture. It's one of those things on the same day. But no matter what I think is reasonable, no matter what I can prove to you CPT says is valid, it doesn't matter. What it really boils down to is what your local payer is going to do. Jan and I have seen every possible permutation of billing for this concept of telemedicine right now. There's no one right way to do any of this stuff. And in fact, CMS has even changed the rules to open up a lot of the telemedicine stuff for the Medicaid practices massively. All right. So depending on where you are and how obnoxious your local Medicaids are and how obnoxious your insurance companies are, you may have a lot of freedom and flexibility here, and you may have none. What I would do in every single instance is pick up the phone and call. I realize, companies like Aetna and United Healthcare, they don't have reps a lot of the time. That's deliberate, but you can pick up the phone and call the AAP, or you can send a note to the AAP coding hotline. You can go to PCC Talk and ask what people are doing there. You can go to the COVID forum and hear what people are doing there. The websites for the payers are being updated, but you can also go to SOPM and ask there. You can find out what other people are doing. Also, to be clear, everyone on this phone call, every pediatrician on this phone call has, as a family who come to you, the CEO or CFO or the controller for the employers who are purchasing these insurance plans. And you shouldn't really have any gumption, or you should have no fear in being able to pick up the phone and calling the CEO of PCC and saying, hey, I have a bunch of your kids who come to me, and I can't get a straight answer from your Blue Cross Blue Shield about how I'm possibly supposed to take care of these kids. You have 110 employees, 20 of them bring their kids here. I want to be able to offer them telemedicine, but I have no way to bill it. Can you help me find an answer? And I will tell you, most CEOs are kind of motivated by stuff like that. They want to keep their employees happy. They need their employees to keep working. When a CEO picks up the phone and calls their insurance broker and says, hey, will you explain to me right now what I'm going to tell my wife or my husband today when they bring the kids to the doctor, why they're not getting covered? Because I thought we paid for that coverage. That has got far more leverage and kick than what you will do as a pediatrician. So please, coming back to the telemedicine thing, in a way, those are the easiest questions I have to answer, because I can answer with it depends every single time. Now, when people are asking here about telemedicine releases, that is entirely state dependent. Okay, completely state dependent. And there are some states that require no telemedicine. There's some states that require only telemedicine for, say, therapeutic visits. Okay, and there's some states that require waivers for everything. And so I think it's really what it boils down to is what's happening in your state, which goes all the way back to the first slide. Now, the last thing I wanted to say that I forgot to say about the slide, this previous slide, this one here, one of the things that telemedicine, I think, has given us the potential freedom to do is walk away from our requirements relating to the schedule. Right now, everyone here is used to, I work from 9 to 4 and I take a lunch break, or I work from, I work Monday, Tuesday, Thursday, Friday. I get Wednesdays off, or whatever the case may be. If you're a solo physician, and you're used to working 24 hours a day as it is already, maybe you don't change. But if you work in a large group practice, and in particular, if you work with employed physicians who are paid with any kind of performance criteria, or if your visits are just down and you are feeling the pain of COVID, you can see patients anytime. There's no reason why you can't take a phone call on Saturday at 10 o'clock. Well, looks like my family went to run an errand together in a car safely somewhere. They went to walk the dog. Well, that's where you can do your 20-minute telemedicine call. You can do 2 or 3. You can do those on a Saturday without having to go into the office, without having to have staff. Anything that you can do that doesn't require you to fire up the engine of the rest of your practice and actually get paid very directly for your skills teaching people and guiding people, which is the most fundamentally important stuff that you do as a pediatrician, that is a really good use of your time. I've been telling people for weeks, be prepared to start working 7 days a week for a little bit. As we catch up, we get everyone to catch up with the with the well visits. So another question, vaccine administration in the parking lot, bill the visit. I'm going to say, yeah, why would you not bill a visit, frankly? If you're doing, now, again, this is going to go back to whatever your local states say, but if you're doing a well visit and you can do, you can do, this is tricky because it really depends on how you want to bill that well visit code and what your payers tell you to do. Some states and some payers allow you to bill the 9939 code doing the telemedicine, and then you either just do the additional procedures later, or you do the additional procedures with sick visit code. It's so locally and payer dependent. I don't have a right answer for you. I know how I would like to do it, which would be to, in fact, bill that 99213 every time with the second visit, but not everyone accepts that. All right, let me see what other questions I have before I get to the end. The Doximity billing question again. When you do a portal exchange or phone call billing, it asks you if the location is telehealth or doctor's office. Is it always telehealth? That is going to be payer dependent. What it should be, if you ask me, if I were king for a day, those should be telemedicine visits, and they should use place of service 11, but that doesn't always work. Some places want place of service 2, which is often followed by a 30% discount because place of service 2 is a facility code. It makes it look like you're working out of a hospital. And some places don't want that code at all. We have some clients who are told when they do a telephone visit, just bill it as a straight 99213 without any indication whatsoever that it is, in fact, a telemedicine visit, which seems like crazy fraud to me. Especially when the codes exist, to let the insurance company know. But what you're seeing there is the insurance companies knowing, well, if a claim comes in here with an 11 on the place of service or a 95 modifier, we're just going to kick it out, and we don't want to do that right now. So it's really what you're seeing is the ineptitude of the insurance companies. All right, so just a sec. That's usually when I'm teaching a class, I let someone ask a question and then I take a drink, but I don't get to do that here. Now, the one thing I do want to point out, this is not telemedicine specific, but in general, when the issue comes up, or I'm going to target it to, or attach it to the telemedicine well visits, because that's the big gray area right now that we haven't totally resolved. I'm saying this from memory. My data may be wrong, but right now, virtual well visits represent 5% of our clients' well visit volume. It's really tiny because everyone's trying to figure out how to do it. One thing to keep in mind is that right now the payers are sitting on mountains of cash, billions of dollars. It has to be billions of dollars if you do the math. For the last 2 months, the overwhelming majority of elective surgeries have been canceled across the country. And that means hospital beds are empty, except for COVID victims. All right. But there are still many hospitals with no one in them where COVID hasn't hit heavily. And the hospitals and primary care is down 30, 40, 50%. So these insurance companies are sitting on billions of dollars and they have no way to get it to you. And they have to get it to you. They have to get it to you because they all have medical loss ratios and other requirements that force them to actually spend money on care. So as it relates to telemedicine, if you're dealing with one of those payers who isn't covering telemedicine functionality, virtual visits properly, this is where you should be leveraging the media, and you should be leveraging your relationship with some of your patients and getting answers to why does Aetna hate children? Why does United Healthcare hate children? Why do these payers not respect the need and importance of well visits? Why does Cigna fear doing depression screening in teenagers? You ought to be that pushy on this stuff. So anyway, back to my slides. Let's do some takeaways here. Okay, so what do we need to remember? All right. Communication to your patients, letting them know upfront what to expect, how the telemedicine visit should work, how they can give information to you in advance. Communicating to your patients that you are open and available for these visits, that you're seeking to help them for the things that are hurting them the most right now, which is all the trouble they're having with at home with sleep and anxiety and so forth. Communicating to your parents, over communicating to your parents is really important. And you have available to you a free blast messaging tool. Okay. So you should be on social media. You should be using your EHR reports to say, you know what I should do? I should send a note to every single one of my families where a kid has a diagnosis of anxiety or depression or any one of 50 diagnoses you wish to choose, or who's on active meds for those things, and send them a note and say, hey, if you're struggling right now, give me a call. We have people ready who can talk to you and help you with this challenge. Barbara Howard, I posted it on my blog, so it's free for you to see. And we also posted in the forum. Barbara Howard gave me 45 minutes talking about the pre-visit screening tools that every one of you can use to leverage these visits. You get those families to fill out those questionnaires, those screening tools, before you even crack open that Doxy Me or Anytime Peds window, and you actually will save time during the visit itself. All right. If it's telemedicine, that means it's less time trying to talk and coax someone into something over the telephone, which is hard. And if it's in person, it's reducing the amount of exposure that you have to a family or they have to you while they're in the office, because you are getting right to the meat of the subject earlier. Planning is a big portion of being successful with telemedicine. And the thing I want to go back and recaution everybody, recaution people about, I mentioned this at the beginning, your use of telemedicine does not have to be perfect. You don't have to have the flawless plan. You do not have to wait for a way to complete a physical exam in order for you to move ahead with telemedicine. The thing to do is try it. The thing to do is figure it out. If you are convinced that a patient needs to come into your office, would you rather see them via telemedicine first and then perhaps make that visit more efficient, or not see them at all, waiting for a time when you've got the master plan sorted out? And obviously it's the former. So try, experiment. At the end of every day, do a little retrospective and say, okay, we did telemedicine, we did 20 visits today. What went well, what didn't go well? What parts of our workflow do we need to change? Do I need to have different staff doing something over here or different staff doing something over there? This is so much in your ballpark. You're so capable of doing this. So just a little bit of communication and planning. Last but not least, I'm going to encourage everyone here to be as flexible as possible right now. Your patients are nervous. Your patients are anxious. They want your help. Pediatricians grossly underestimate the positive impact they have on families when they converse with them and they talk to them. And for you to reach out to them and say, call me, let's get on the phone, let me talk you through this. That is not only how you're going to help your patients the most right now, it's also how you're going to help your practice. So figure out the best times to do this. Figure out the things that make you the most comfortable, and roll with it. You don't have a choice. Okay, let me see. Any more questions? I was expecting like a landslide of telemedicine questions. So let me then, since we don't have any more questions, let me go back and mention one thing that I spoke about at the kickoff today that I think will change the workflow for a lot of you. And I want people here to be prepared. So we've released certainly half, I think the important half of our curbside check-in process. We haven't released it. What am I talking about? We're testing it. Literally, as I'm speaking, our crew is testing the functionality relating to how to alert patients in your out in your parking lot that they should, you're ready for them to come in now, whether it's to your lobby or to a waiting room or whatever the case may be. So you will have very shortly a direct texting tool, a button from right in the EHR where you can be in the chart note, you have your message, which by the way, I believe you can access just by typing one of our new upcoming little snap messages. So you could type like, I'm making this up, .tm3, hit enter, and it would go bam. Hey, please come in and go straight to room 3 on the right. Your appointment is ready. And it's all done automatically. So that's coming, and we don't know fully how it's going to work its way into our clients' workflows. So I want everyone here to do a little planning and think about it, and that will help us figure out what features we need to add to it or amend. All right. So I see some people typing. Does anyone sign people up for portal over the phone instead of in person? If so, is that legal? Oh, I'm going to say there's no legality whatsoever that I am the least bit aware of that should be a challenge. And right now we have people who routinely sign people up over the phone. I actually think the phone, if you have a way of confirming that you're speaking to the right person, is a more secure way of signing someone up. But with the release that we're testing right now, we're going to allow people to sign up using their cell phone numbers, not just their email addresses. So you will literally be able to take a cell phone number from a family. You can create their portal accounts, and they will be alerted that their portal account has been created, and they can go right to their portal with a direct message, with the message that they receive. So I think that's pretty cool. All right. Any more questions? You know what? I'm flying through these webinars. Normally I run out of time, but right now I'm talking too fast.
No,
I just
man,
need to
you've got
slow
it all
down.
covered.
You know what? Usually I've got, I don't know, what do I have? 15 slides, 17 slides. 17 slides, I can get 90 minutes out of 17 slides. And clearly I can't do that right now. So this is my struggle, everyone. All right. If we do not have questions, we'll wait here for a few minutes, but we'll turn down the webinar and let you get back to your days.
Well, while everybody's thinking of their questions, there's a couple things to share. Our next session is at noon Eastern tomorrow. Kate Taylor of PCC will present a session titled Patient Portal Use in the Age of COVID-19. And hot off the press, we did the last 5 minutes. You can now find the entire week 2 schedule listed at pcc.com/UC-2020.
Oh, so what are some highlights, Jan?
Some of the highlights. So what's been added for week 2, so this begins again the Tuesday after Memorial Day. AR collection strategies, insurance billing workflows. There will be 2 presentations about the June COVID release. So some of the teasers that Chip gave you today will be fleshed out, and there'll be much more detailed information and some awesome training for that June general deployment. And so Chip will return next week with recall strategies. There'll be guidance for getting the most out of your relationship with your PCC client advocate, and improving your practice health with the Vitals dashboard, among other things. But we'll hold some things for you to discover and fall in love with at the website.
All right. That's pretty awesome.
And there's a link posted in the live session to the survey for this course as well. There are unique course surveys for each course that I've been posting toward the end of each session. So please be sure to fill those out. They are, believe me, as part of the education team that helps to put all this stuff together, we refer back often, and we depend heavily on the things that you guys put in those surveys to guide us. And when we can go in 2 directions, sometimes we take your guidance and force us in the direction of greatest interest and need. So please get that stuff in there for us. Absolutely true.
All right, we're going to end the webinar here, and we'll be in the chat for a little bit, and to help answer questions. But if people need anything, you know where we are. It's still chip@pcc.com and jan@pcc.com, and ask your questions in the lobby and in the live session as well. We'll take care of you there. All right.
We will.
All right. Thank you very much, everyone. Appreciate it.